Welcome to Impact Education's CARE Team Talk CE program, payer-provider collaboration to meet best practice standards in asthma management. I'm Steve Calusi. I'm the principal consultant with Calusi Consulting LLC. Today's program is jointly provided by Partners for Advancing Clinical Education and Impact Education LLC and is designed for 1 contact hour of continuing education credit. This activity is supported by an independent educational grant from AstraZeneca, and we'd like to thank them for their support. At the end of today's program, you'll be able to complete an evaluation, which must be submitted to receive credit. Click Complete Evaluation in the navigation within the activity. Once you complete your evaluation, you must click Claim Credit to download your certificate or for pharmacists to submit your credit to the CPE monitor. Today's discussion is designed to bring asthma care team providers and managed care perspectives together around the shared goal of improving asthma outcomes. We'll focus on what effective patient-centered asthma care looks like in the real-world practice, how current guidelines and emerging quality measures such as the HEDIS, follow-up after acute and urgent care visits for asthma, or the AAF-E measure, inform treatment decisions, and where barriers to appropriate care still exist. Throughout the conversation, we'll explore how multidisciplinary team-based approaches can reduce delays in diagnosis and treatment, improve care transitions after urgent or emergency visits, and strengthen collaboration between primary care teams and health plans to ensure patients have timely access to evidence-based asthma therapies. So with that, I'd like to take a moment to ask each of our panelists to introduce themselves. Carla, we'll start with you.
Hi, I'm Carla Stormer-Grossman. I'm a bachelor's prepared nurse and a certified asthma educator. I work for INHALE, which stands for Inspiring Health Advances in Lung Care. It's a clinical quality initiative funded by Blue Cross Blue Shield and housed at University of Michigan.
Thank you so much. Welcome. And how about you, Dr. Lugogo?
I'm Dr. Njira Lugogo, and I'm a professor of medicine in the Division of Pulmonary and Critical Care Medicine at the University of Michigan, where I direct our asthma program.
Thank you so much, and I will turn it over to Drake to introduce himself.
Yeah, thank you, Steve. Hello, everyone. Drake Ryder, currently working as Director of Pharmacy Operations for Priority Health. We're a health plan based in West Michigan, do business in 4 states in the upper Midwest, and I am a pharmacist by background.
Excellent. Well, welcome to you all. We're very excited to have such an esteemed panel here, and we have a really unique type of activity that we're going to run through today. We're going to have 3 cases, and without further ado, I'm just going to jump right into our first case. So guideline-appropriate treatment of severe asthma entails referral to a specialist for consultation or co-management, especially after an exacerbation. However, a substantial proportion of uncontrolled patients with severe asthma have no evidence of specialist visits or medication escalation after uncontrolled disease, and there's a relationship between uncontrolled disease and subsequent healthcare resource use and exacerbations. Results from Carr et al. Demonstrated that many patients with uncontrolled severe asthma presented no evidence of escalation of care after uncontrolled disease. And furthermore, non-white patients had lower rates of escalation of care after uncontrolled disease, indicating possible racial disparities within asthma care. These kinds of findings highlight the need for improved guideline-based care delivery to patients with severe asthma, particularly for those facing social disparities. Efforts are needed to increase subspecialist referrals and potential medication escalation for patients with uncontrolled asthma. And so to start us off, considering the gaps that we are seeing in care for patients with uncontrolled asthma, I'll come to you first, Dr. Lugogo. Can you walk us through the goals of asthma care today and highlight some of the key barriers that prevent those goals from being met?
I think the goals of asthma care are quite clear today. So 1, we really need to focus on preservation of lung function. And I really feel that's important to preserve the function of the organ that's involved with the disease and prevent progression over time. 2, we really want to focus on mitigation of oral corticosteroid utilization and reducing those long-term risks associated with recurrent exposure to oral corticosteroids. Now, thirdly, we certainly want our patients to have good asthma control in terms of symptoms, but I think we over prioritized symptom management and under prioritized mitigation of risk and reduction of both deteriorating lung function over time and oral corticosteroid utilization. And that has meant that for many decades, we've undertreated people who don't complain of asthma symptoms and yet may have ongoing inflammation, exposure to oral corticosteroids, and deterioration of lung function. And perhaps in some cases, we've overtreated symptoms that were not actually directly tied to asthma and were extrapulmonary in nature. And so, we really need to start focusing on understanding the pathophysiology of asthma, what's driving the patient's disease, having our patients collaborate with us on mitigating risks, and finally, really controlling the disease, focused on inflammation and somewhat on bronchoconstriction, but not being overly focused on constriction and symptoms and overuse of short-acting beta agonists in an effort to chase symptoms, but really partnering with our patients, helping them to understand that we need to have goals of treatment that are much more appropriate. And at the very end of the day, what we are seeing with our patients is end organ damage, both in terms of their lungs, but what we are now calling people remodeling, which are consequences of poor treatment of asthma over decades and overexposure to steroids, leading our patients to develop all kinds of problems in other organs, ranging from cardiovascular risk, ophthalmology problems like cataracts, issues with bone density, metabolic diseases like diabetes and obesity, and even the development of comorbid anxiety and depression. And so at the end of the day, all of us need to really focus on the fact that asthma may be a lung disease, but the consequences of poorly treating it are extrapulmonary and pulmonary. And we really need to be focusing on actually treating the whole patient and intervening early, preventing long-term negative consequences of poorly controlled asthma.
That is so interesting. Thank you so much for setting the stage for us. It really does sound like we're chasing our own tail in some ways by trying to treat the symptoms and ultimately undertreating our patients and then not preventing those downstream adverse outcomes. So, Dr. Lugogo, I'll stick with you for this next question. Then, for those who might not yet be familiar with it, can you describe the HEDIS AAF-E measure and what it signals about priorities in asthma care?
So I think this measure is a good start. Let's just say that. So just to describe it further, the HEDIS AAF-E measure is really focused on follow-up after acute and urgent care visits for asthma. Now, this measure just started to be implemented this year by NCQA, and it focuses on improving poor and disparate asthma outcomes by encouraging the use of outpatient follow-up care for and after an asthma exacerbation. The measurement is the percentage of persons 5 to 64 years of age with an urgent care visit, acute inpatient discharge, observation stay discharge, or ED visit with a diagnosis of asthma that had a corresponding outpatient visit with a diagnosis of asthma within 30 days. So that's a lot of information I just shared. So what does it mean in practical terms? It means that we need to recognize that a person that has had an acute visit for asthma has now had a treatment failure event. And that subsequent to that, we need an appropriate action. Now, what this measure is encouraging us to do is see that patient within 30 days. I think it's a good first step, but it really needs to be followed by a very proactive intervention during that visit. So if we bring that person in and we do what you already mentioned, Steve, which is practically nothing, doing nothing, don't change the treatment, just have the patient come in, talk to them, and leave them on the same medication, which is what you mentioned when you introduced this symposium, this episode of our discussion, then we've achieved nothing. But I think what they're trying to say is we all recognize something is wrong. The patient had an acute event. This is a treatment failure. Bring them in. And subsequent to that, we need to make an appropriate adjustment to treatment to prevent future harm. And so we all have some data that tells us that we aren't doing this very well. So, 6.5% of patients and 8% of adults in 2021 that had asthma actually, came in and had an acute event. And on top of that, we have unmitigated deaths related to asthma. 10 people on average a day in the United States die of asthma, approximately 3,500 deaths in 2021. And unfortunately, children are not exempt from dying from asthma. A lot of these deaths happen outside of the healthcare system, which means that either the patient was not aware that they were in trouble or they didn't have an appropriate treatment plan. And we see disparities in the people who are actually having more burden of disease, both acute episodes and also, unfortunately, deaths related to asthma tend to be disparate in terms of both racial distribution, and sometimes patients from more impoverished areas or lower socioeconomic status bear the burden both of more symptoms, more exacerbations, and higher mortality. And unfortunately, we are using up a lot of resources and not improving outcomes. And so we do see a significant consequence of uncontrolled asthma. It's very costly. We are spending billions of dollars in asthma care, but not having appropriate outcomes. Consequently, we are seeing people still accessing asthma care in acute settings. We see a high number of emergency room visits, particularly in children, and we see a high number of hospitalizations, which is not really the place we want our patients to go to get chronic disease management. So we really are managing asthma as though it's a repetitive acute illness, kind of like you would manage a viral illness or a cold or an episode of infection like COVID. And in between those acute episodes, there's virtually not much asthma care occurring until the next acute episodes happen. And so what we really need to do is have a paradigm shift in how we think about asthma. Although these acute episodes that are happening are highlighting that the patient is uncontrolled and needs some different treatment, it truly is a chronic disease, and we need to partner to manage the patient in between these chronic diseases. And so I really think this measure is a good start. I'm eager to hear from Carla and Drake about how they see this measure changing how we manage patients with asthma. It certainly feels a little bit reactive in that we are coming in after the event has already occurred, but maybe you need to strike while the iron is still hot. While the patient has just had an episode, maybe they're really thinking about their asthma. We are all more oriented to the fact that something is not okay, and perhaps it provides us an opportunity across multiple platforms to figure out a way to make a change and steer the patient into a new direction with the shared goal of preventing future events. And so with that, I'm really eager to hear what Carla and Drake think about how this new measure may present us with an opportunity to revolutionize our care of patients with asthma.
Yeah, that's fantastic. Thank you so much for that summary. And I really love that analogy, striking while the iron's still hot. And so, Carla, I will come to you next. I think Dr. Lugogo teed you up really nicely. How do you think that the HEDIS AAF-E measure changes expectations for care teams and health plans when it comes to managing asthma?
I really agree with Dr. Lugogo's points, and I really want to highlight that our real goal really should be to avoid the exacerbations in the first place. This is more of a like an exclamation point or a highlight saying, hey, this patient's actually in danger. And so I think that in order to for the team to actually work together, we really need to work on communication, and that has to happen at all levels. So the people that are doing the triaging of the phone calls, that are getting the faxes maybe from the ER, the urgent care is saying that the patient was there, that patient should be identified at all of those levels, so that when they do come in or when they do call or when we reach out to them, everybody understands why we're doing this. Because an exacerbation, as Dr. Lugogo put so well, is truly a failure of care. Something has happened somewhere, maybe on the patient side, and maybe that we haven't prescribed them the right amount of medication or the right medications. So it is really truly incumbent on the team to have all of our roles. How are we going to identify that patient in the first place? How are we going to what are we going to do when that patient comes to see us or when they call us? I'm thinking about a practice that we've worked with recently that created purple folders. And the patients were identified. If they had the diagnosis of asthma, they were given this purple folder, and the purple folder followed them, including in the when they were scheduling their appointments, they were highlighted as purple. So even the schedulers knew, oh, this is an asthma patient. I need to make sure that they have enough time to talk about their asthma. We need to make sure that when they do call in, that they are given appointments. Timely appointments. And so each role had that opportunity to say, okay, what do I need to do? And they had their roles defined with that kind of visual cue of that patient being an asthma patient. So again, we need to think about phone triage, scheduling, refill calls, visits after ER visits or hospitalizations or urgent cares. Those are kind of like as Dr. Lugogo said, reactive, and we need to think about it as proactive. I think one of the things we can do to be proactive is to really communicate to the patient the expectations of what they should expect from their asthma. That I know that I've worked with a lot of patients that just assume that they're going to have exacerbations. Of course, my child's going to have multiple exacerbations during the school years. That's just the way they've always been. So we need to reset that normal. What does normal really mean for asthma? It means that you should be able to do what you want to do. You can go live your life. You sleep through the night. You can exercise. You can be an Olympic athlete if you wanted to be, if you have those qualities. But we need to reset that instead of letting people think that their current abilities or their current control is their normal. So we need to really explain what good control looks like, and also that risk of oral steroids. I know that a lot of patients are very, very comfortable with oral steroids. I talk about patients that have had 8 to 9 to 10 oral steroid bursts per year for most of their life. We kind of use it like we just toss it out like candy. We really want to make sure that they understand and that we fully understand the long-term negative effects of oral steroids on the body, what Dr. Lugogo was talking about, people remodeling. And that really has been a big paradigm shift, I think, in asthma care. And I think as our team members and understand that impact of oral steroids on the actual person, what happens to them, what can happen to them with repeated use, I think that will really help patients and for the long term and in the short term. So they having that understanding of how and when to escalate their medications and avoiding oral steroids if they're having an exacerbation, what medications they should be taking every single day, and that could help them not have those oral steroids. So again, I think it's fully into communication and education, both of your team, so they understand what those expectations should be, and also of the patient.
Fantastic. Thank you so much. Drake, I want to come to you next and ask a question, from the payer perspective. What kind of patterns in utilization do you think payers need to be aware of to understand when asthma care goals might not be met?
Yeah, thanks, Stephen. Just a quick opening comment. I got to say it's very illuminating to be on this call with these clinician experts. I've already learned so much. Looking forward to learning more. To get to your question, I think there's kind of two ways I look at this in terms of utilization patterns. On one hand, I'm thinking through areas where you'd see an increase in utilization, which indicates goals aren't being met. So some of the things that have already been hit on are you seeing an increase in urgent or emergency care visits among this population, hospital utilization, essentially things that indicate that exacerbations are clearly occurring in this population. I think the other thing that has been talked about quite a bit is the use of corticosteroids, trying to avoid obviously the reliance upon that. But I think from a pharmacy data standpoint and something that would be very real time and easily queried within any health plan database would be, are you seeing a spike in corticosteroid use, obviously in patients who have these associated diagnosis codes. So that's, one area or thing I look at. I think another utilization increase I would look are, and I don't know if this is always necessarily indicative that goals aren't being met, but if folks are also, if you're seeing a spike in diagnoses that I think are also common in patients with asthma, whether it's like atopic dermatitis, some of the other like allergy type diagnosis codes, could that indicate that there's an increase in asthma, or maybe some of those goals are not being met? On the flip side, I think there's also things that you would look for decrease utilization patterns. Number one would be a decrease in visits with the provider who's managing their asthma. So that could be, either their PCP or specialist. Are you seeing a decrease in routine labs? Some of the things that indicate routine monitoring. Obviously, with the HEDIS measure, following an exacerbation, are you seeing a drop off in visits? I think that would be one thing. Obviously, on the pharmacy claims side, are there inconsistent or patterns that indicate utilization of medication is not occurring as prescribed? So is adherence low? Are patients, not taking those medications as prescribed? Or are there increased bills associated with some of the short-acting, more rescue type medications? I think those are all the various utilization patterns that I would look at to show, either they aren't managing the symptoms well, they're not engaging with their care team, or they're experiencing exacerbations.
Can I add something about the importance from that care team perspective? And thanks, Drake, for bringing this up. Is that part of that education is inhaler education, device education, how to actually use your device, and adherence monitoring. Are the patients actually going to the pharmacy and picking up the medication? You can't really look at fill dates. You have to really look at pickup dates, and that making sure that that patient has the right inspiratory effort to use the device correctly, can demonstrate how to use the device correctly, is using a chamber with their meter dose inhalers. All of those things will help lead towards better control, and are things that you could be doing as a proactively set up that patient to have less exacerbations.
Yeah, that's a really good point. And I think what's interesting about adherence when you're talking about oral medications, I think normally the general rule of thumb is possession is 9/10 of the law, right? Having that claim filled, for an oral medication, you can relatively safely assume that the patient's taking their medication. But when you're talking about inhalers, it's not quite that simple, because even if they are very well intentioned, these patients might have some educational gaps with regard to how to properly use their inhalers. If they're on different devices that have different administration techniques, that also complicates things. So I think to Drake's point, having all of the data is extremely helpful, but this is one of those situations where we need both, back end and front end support when it comes to adherence monitoring. And so this is a really good conversation. I want to also now move into a patient case here. We have a 42-year-old woman with asthma who presents with ongoing symptoms despite treatment with a low-dose inhaled corticosteroid and long-acting beta agonist. Over the past year, she's had 2 courses of oral steroids and 1 asthma-related urgent care visit, along with frequent nighttime symptoms and daily rescue inhaler use. Her treatment hasn't been escalated in the past 2 years. Spirometry has not been repeated, and no specialist referral has occurred. She also reports concerns about medication costs and insurance coverage, which may be contributing to delays in appropriate escalation of care. Dr. Lugogo, I'll come to you first with this one. Based on this case, how would current asthma guidelines inform the next steps in this patient's therapy?
Well, that's really a good question. But I wanted to make a few points before I delve into the guidelines. One, this is our classical patient we see in the clinic, a patient in her 40s. And that hasn't been assessed very much in the last few years in terms of not having much spirometry testing done. So if you're really looking at for end organ damage, you have no measure. And oftentimes the patients might not have ever had spirometry. So the fact that this hasn't been repeated means she had it at some point. The lack of treatment escalation is honestly pretty classic. Oftentimes, though, people went from not very much treatment to the maximal dose of inhaled steroid with a long-acting beta agonist and just stayed on it forever. So we see both sides, the undertreated and the, oh, I got a certain dose and now I have no symptoms, so I'm not doing anything else at this point. And she clearly is completely uncontrolled. So she's had 2 courses of oral corticosteroid. She's also had an urgent care visit, a lot of symptoms, and is completely uncontrolled. So if you really look at this kind of patient and you look at our current treatment paradigm, what we would say is that she has one of 2 options. One is to escalate the inhaled corticosteroid dose in this combination inhaler and continue to give her the same rescue treatment that she currently has. And that's presuming that this is a patient that is on a non-formoterol containing regimen. On the other hand, this is a patient that potentially could be a candidate for maintenance and reliever therapy. If she has a formoterol containing inhaler, she could use that for maintenance and for reliever. And the third option certainly would be, and this would be my preference, is to understand what type of asthma the person has. You know, are they having eosinophilic inflammation? Are they particularly allergic? Do they have high nitric oxide, which indicates what we now call type 2 asthma? And if you look at the most recent GINA strategy document in 2025, they do have an appendix that tells you that you need to start to risk stratify the patient, understand what kind of inflammation they have, what their prior history is, what kind of comorbidities they have. You have to manage those extrapulmonary comorbidities. You also have to go ahead and make sure they know how to use the inhaler and they're adherent with therapy, and that they're not smoking or having any kind of environmental exposures. So there are a lot of opportunities in this case to really engage with the patient. It would take some time, though. This is not a 5-minute or 10-minute return visit, because you have to really assess the patient and get a good idea of what's going on. The last comment I would make is that, you know, unfortunately, inhalers cost a lot of money. And there are some generics on the market. We are slowly seeing more and more generics. More insurers are now covering guideline-based treatment, which is either that formoterol containing inhaler, so you can get 2 a month. You can use it for maintenance and reliever, or they are agreeing to cover inhaled corticosteroids plus a short-acting beta agonist, either in one inhaler or in separate inhalers, sort of pushing that idea of anti-inflammatory reliever therapy. Because certainly when patients have acute symptoms, they have inflammation and constriction, and both need to be targeted at the same time. And we are treating an inflammatory disease here. So we are always targeting inflammation and constriction, while also being cognizant that overuse of both high doses of inhaled steroids and oral steroids have some consequences we have to be aware of. So we are needing to right size the treatment to the patient. So there are also opportunities there to add a third drug, either in a combination triple inhaler or separately to the second inhaler. So it's a bit nuanced, and maybe that's the problem with asthma care, is that it's not very easy and straightforward. But I do think that understanding the basic principles that we need to prioritize anti-inflammatory reliever therapy, think about adding the triple, phenotype the patient to understand the mechanisms, and then escalate people appropriately for subspecialty care, particularly if you're thinking they might require a biologic, and then measuring that lung function and having some confidence that you understand the extent to which that end organ has been affected by asthma.
Drake, what kind of strategies can the care team or payers use to ensure that the patient has timely access to evidence-based treatment options despite her cost concerns?
Really, what the core strategy comes down to some of the more, basic blocking and tackling around sound formulary and utilization management. And what do I mean by that? It's essentially taking not only the guidelines, but other best practices, that Dr. Lugogo and others who specialize in this themselves, and essentially designing a formulary to reflect that. So, ensuring that in each of those classes of medications, there is a pathway to access. If there are criteria around those, they're not overly restrictive in terms of, overstepping what label may indicate or what guidelines might recommend for who's eligible for those. Outside of that, I think a few things that really come to mind. Obviously the different access channels can be pretty confusing. There's retail, mail, specialty. There's now a lot of direct to consumer. I think the role of the payer is to, try to have as many of those be available as possible to members, but also to help, educate and guide, because it can get quite confusing. You might have to get a biologic through your specialty pharmacy versus an inhaler can be obtained through any channel. I think the overall goal should be to keep as many of those open so that you're also ensuring more equitable access to those medications. And then a few other things that come to mind. I have seen some creative ways that payers try to encourage better adherence, engagement by reducing or eliminating cost sharing over time as a member or patient continues to remain on those medications and engage in care. I think payers can play a role in facilitating responsible, being the key word, access pathways to reducing cost share where available. So things like, copay assistant, other discounts that are available. I think the key with that is obviously to make sure that you keep those patients within the system and that you don't leave them without coverage. So that's where the responsibility piece really comes in there.
And Carla, I'll come to you next. When should primary care clinicians consider referral to an asthma specialist, and what kind of barriers typically delay that step?
I think with this patient, like Dr. Lugogo was talking about, there's so many opportunities for optimizing care at the primary care level. I think really trying to figure out what happened. Why did she end up on those oral steroids? Was she able to be adherent? If she wasn't able to be adherent, why was that? It was because of the cost of the inhalers. Optimizing those treatments first, and then moving on to a specialist if they feel like there's something else going on, or if they've tried everything that they feel that comfortable in their particular toolbox. We know that some providers feel very comfortable moving on to like biomarkers and contemplating biologics and looking into that more deeply. And then other providers know where they feel comfortable, and then that referral is absolutely appropriate. I do know that depending on where you live, right, there can be some significant delays in getting in to see a specialist just due to scheduling issues. Some of the things that you can do in advance to help that appointment get through is have those biomarkers already drawn up. You have that information and are able to share that. I think Dr. Lugogo's mention of the spirometry is really important to have that and to truly understand, as she said, what type of asthmatic you're dealing with.
We're actually going to move into our next segment here. I want to talk a little bit more about patient-centered asthma care, and interviews and focus groups with individuals with asthma and their caregivers led to some very interesting findings. Among both adults with asthma and caregivers of children with asthma, the most desired outcome was relief from symptoms that limit what people with asthma can do. Participants valued symptom relief that would allow individuals with asthma to be more physically active. Caregivers also wanted to reduce the number of hospital visits and, on top of that, to control nighttime symptoms for these individuals with asthma. Interviewed participants stated that cost and insurance coverage, safety, side effects, benefits, success rates, and asthma severity all influence their decisions about asthma treatment, and some participants were concerned that they might become dependent on or addicted to asthma medications, in particular to pills. The participants with comorbidities expressed concern about drug interactions and contraindications, especially for oral medications. So, Carla, I'm going to come to you first this time. Given all the concerns about symptom burden, nighttime control, avoiding hospital visits, how can a multidisciplinary care team work to reduce delays in diagnosis and treatment?
I'm going to go back to my original comment about the importance of communication and education. I think that care team at all levels, again, going all the way from that person that's answering the phone all the way to your providers, need to understand what good care is. And then we also need to educate our patients on what to expect from their asthma. And I think that we often don't ask all of the questions. So I think the person that is potentially like rooming that patient, making sure that they know that asthma patient or that patient is an asthmatic. They may not be there for asthma, but let's ask those questions anyways. Have you had daytime symptoms, nighttime symptoms, symptoms with exercise? Are you able to do the things that you want to do? Are you restricting any of your activities? Have you decided that you're no longer going to walk the stairs? You're going to be taking the elevator now. So trying to query those patients, make them kind of think about it all the time. Have I had nighttime symptoms? Have I had daytime symptoms? When's the last time I used my short-acting beta agonist or my reliever? Maybe it's the anti-inflammatory reliever. How often are you using that? And talking about that all of the time, making that really, really common, and making sure that all the people understand why we're doing it. So the MA rooming the patient, the RN talking to the patient on the triage line, maybe the provider that's seeing them for something else can still query them. I think also using patient-reported outcomes such as the ARQ or the asthma control test would be really helpful. I do know that it's really, again, important to make them realize that being short of breath or not exercising or restricting your activities is not normal. I think that you can ask those questions at all the times, making sure when you do talk about medications, you don't ask them, are you taking this, 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 and this? Because patients will often just say yes. You really need to ask them more open-ended questions so you can get more information out of them.
Dr. Lagoga, I'll come to you next. How do nurses or pharmacists support patient-centered care in your practice?
I will say that nurses and pharmacists are critical to my practice. We have a group of a group of pulmonary nurses in our clinic. They do all the triaging. They take every opportunity to educate patients when they call in with acute symptoms. They guide them through options for treatment. They communicate with me and we co-manage these patients. They educate patients in the clinic on inhaler technique and sometimes even on things like adherence, and often talking to the patients when they're acutely ill and alleviating their anxieties, reminding them what the action plans are so that patients feel empowered to manage their symptoms, and also encouraging them to follow up. So I couldn't survive without the nurses, for sure. And then we have a very robust specialty pharmacy at the university, and they manage all the education around specialty drugs, and also follow patients that are started on specialty drugs and do multiple check-ins after a few months, and then eventually every 6 months, where they remind patients to be adherent. They address any concerns patients have about side effects. You had mentioned that. They communicate some of those issues back to us. And they also honestly are helping us tremendously with the prior authorization processes, which sometimes require appeals, additional documentation, and helping us navigate that landscape for, our patients that have severe asthma that require those biologic drugs. And in our particular practice, the pharmacists are not teaching about inhalers, but I know in primary care and of course in retail pharmacies and other locations, they are the backbone of providing education to patients related to medication utilization and appropriate inhaler therapy.
That's fantastic to hear, and I don't know that that's necessarily going to be across the board, but if nothing else, then there are certainly opportunities for other practices who don't necessarily have that level of support, let's say from a specialty pharmacy, to partner with those individuals or those organizations. So, Dr. Lugo, I'll come back to you before we go back to our next case here. Can you share any examples of workflows that have reduced repeat emergency department visits in patients with asthma?
Yeah, I certainly can. I think the first thing is awareness, because sometimes we are not aware that the patient is not doing well. And so oftentimes getting a communication from the emergency room directly to us, often the tendency is to ask the patient to schedule a follow-up, which is okay, but it's not a closing the loop very well. So when we get a message directly from some contact from the emergency room, or within our own health system, you can get a message in the EMR that says, hey, so and so was in the emergency room, we were hoping that you could see the patient in follow-up. And so having some contact to close the loop to enable us to be aware that this treatment failure event has occurred helps us to then bring the patients in, assess their medications, figure out if they need treatment escalation and re-education. And so that's been quite important. And I think that's going to be the linchpin of this HEDIS measure that's been created, is how do the people who are required to do the follow-up figure out that the person needs the follow-up? And that's going to be really the most critical component. And I think that's where the payers are going to be helpful in creating ways of flagging these events in a timely fashion. And also our health system is going to have to create ways to make sure we are aware that a person needs follow-up.
Yeah, it sounds like it comes back again, simple intervention, just communicating more effectively and not necessarily relying on the patient to do that for themselves. So that's great. All right, well, we have one final case that I'd like to present as we talk a little bit more about access to asthma therapies. We have a 35-year-old man with moderate to severe asthma who's had multiple primary care visits and one emergency department visit over the past year due to poor symptom control. His clinician recommends stepping up therapy based on current guidelines, and so he continues to rely on his rescue medication and misses work due to symptoms. A nurse care manager identifies that the patient has not received education on inhaler technique and is unsure which medications are covered by his insurance. Although guideline-directed therapy is recommended, gaps between the care team and the health plan may have contributed in this case to a delayed access to appropriate treatment. And so, Drake, as our payer representative, I'd love to get your thought. What role do you think payer organizations can play in ensuring appropriate access to treatments for asthma?
I think it's a major role, and it's everything from kind of the front end or diagnosis piece. So when you think about things like network design and access in terms of being able to see providers, including specialists. When you think about the equity of access as well, so things like telehealth, I think that's all wrapped into the network piece. So payers are playing a role in designing those and thinking through how can we optimize access and speed to diagnosis. So that's one element. I know we talked a lot about the drug piece or the medication therapy piece previously. But not only that, when you think about benefit design on the medical side as well, whether the various lab tests, other, sort of routine visit needs that these patients are going to have, as well as acute needs that they may have. So payers play a major role there, even though it generally doesn't fall within the pharmacy side when it comes to specialist appointments and things like that. Payers are still playing a role there. And then I think kind of an emerging area is in the realm of technology. I know federally within CMS, there's a major push right now around kind of not only the portability of data, but patients being able to monitor their own conditions in real time. I don't know if anything has touched on asthma specifically, but I think it just shows the general theme of, what role can payers play in, optimizing that use of technology? Again, is it tied to some sort of adherence program? Are there specific partnerships that payers can help establish? And I think as the entities who sort of drive the incentive structure, there's a huge opportunity there. And technology is definitely an emerging area that I see.
Yeah, you raised the point of technology. I think that's a really timely thing because noticing in some data that more and more payers are turning to predictive analytics to identify these patients based on all of that data that payers are collecting to determine if they're going to be at risk and then making earlier intervention and reaching out to providers ahead of time as well to flag some of those opportunities. But having worked directly in that care management space in the past, I can certainly relate to the point that you made about the health plan just sort of bridging the gap between provider visits, whether it's between an ED visit and a PCP or a PCP and a specialist, or even just between PCP visits in general. So I think there's a lot of opportunity, and the payers can certainly play an active role in that. Dr. Lugogo, where do you see the biggest opportunities for primary care teams and health plans to work together?
The beauty of HEDIS measures is that they are applied and reported at the payer level. So there is an incentive for the payers to help the providers to perform better because there is an implication. So right now, for example, this post-acute care measure, it's the payers are going to be really incentivized in a way to make sure that patients are receiving appropriate follow-up. And that those are some of the things Drake was highlighting, utilizing technological advances, leveraging large data, EMR, being able to work with data marts. And, there are a lot of companies out there that are taking large volume EMR data and figuring out how to flag that patients have had visits. There are currently data flows that flag hospitalizations and ED visits almost in real time, but urgent care is a bit tricky, and it is included in this measure. And so urgent care tends to be much harder for us as clinicians to know. Patients can go to a variety of urgent cares. It's not that easy in data flows to mark who's been to an urgent care. And so I think the payers are going to leverage some of the things that are happening with large data, AI, and other ways to actually increase the opportunity to identify people in a timely fashion. And then what I think is another opportunity is that in asthma care, there are really no best practice measures incentivized to providers. And so is there an opportunity for the health plan to, within the context of what Drake had mentioned, which is incentivizing, best practice and good care, are there opportunities for payers around the country to implement perhaps this same measure, but to give the clinicians credit, the primary care providers, some sort of incentives to perform on a higher level and to actually help the payers meet this actual measure. So I think it's a wonderful opportunity for payers and providers to partner, payers to maybe incentivize primary care health plans to perform better, and also for our payers to perform better. And in so doing, creating certain streams that will allow us to identify patients in a timely manner. And then leveraging those opportunities to actually improve asthma care when the patient is there in the clinic within that 30-day window.
Excellent. Yeah, that sounds very reasonable and very realistic as well. I think the incentives that you talk about are certainly feasible from the payer perspective and would certainly work to help address some of the prescribing issues and also help prescribers identify some of those opportunities to enhance patient care. Drake, I'll wrap up here with our last question. What kind of payer tools or programs do you think can help improve care coordination and timely access to appropriate asthma therapies?
I love what Dr. Lugogo talked about in terms of incentivizing PCPs to provide quality of care. I think payers want the same thing, and oftentimes we talk about these things in silos. On the provider side, we talk a lot about things like gold carding, eliminating prior authorization. On the payer side, we talk about total cost of care. I think everyone's kind of interested in the same goal, and I think technology can help us operationalize that. Things like streamlined prior auth, gold carding, also facilitating some of those total cost of care type agreements. Outside of that, I think there are other programmatic things that payers can do. So I mentioned care management. Another thing that I had thought of prior to this, and I'm glad it was validated early on, was the discussion around pediatric patients. I feel like it's an overlooked population, and I think it's unusual for a payer to have a clinical program focused on that population, but because they're so heavily impacted by asthma, similar to like how you would set up a care management or MTM program, but is there more of a hands-on clinical approach, or if it's just something that can be used to, again, bridge the gaps in that population, I think is one. Another strength I think payers have and tool they can use at their disposal is around data. I think nobody else really has the same global view into data that payers do. So when thinking about some of these things like predictive analytics, as you mentioned, who are my most at-risk populations? Is there a way to, again, continue to leverage some of this emergent technology to help, promote earlier interventions, proactive monitoring of various trends, some of the utilization trends we talked about earlier, whether it's an increase in some of these, acute care visits or use of corticosteroids, and that can be deployed within the various programs that payers host, within some of the total cost of care arrangements or value-based arrangements they may have in place with providers.
Excellent. Thank you so much, Drake. Carla, Dr. Lugogo, this has been a tremendous discussion. And at this point, I would like to open up the discussion to our audience for some Q&A. So we got a few really good questions in here. The first one is, I'm going to go to you, Dr. Lugogo. Do you expect that meeting the HEDIS measure will actually improve patient outcomes?
I think the answer is it depends on what you do when you see the patient in those 30-day windows. So the HEDIS measure itself is highlighting that there is an opportunity and that a treatment failure has occurred. And it's providing the clinician and the patient with the opportunity to meet shortly after that acute episode to determine what the next steps would be. And so, we've looked at some data on our own here at our institution, and oftentimes after acute episodes, nothing changes. And so the question is, will this opportunity to get the patient in front of you and have a discussion about how they are doing make a difference? It does matter if it's associated with asthma or COPD. And so I think, it just really highlights a need. Hopefully it highlights an opportunity and a gap, and that providers will utilize that opportunity and that patients will be attentive to your interventions, because most of our patients, once they go back to feeling well, are rather disinterested in changing anything because their perception is they've gone back to feeling well and they might not want to come in and make any changes. And so it really is going to be dependent on all of us to use that opportunity to enact some sort of change in the patient's treatment in order to prevent future events.
Yeah, I think that's such a great point that it's not just about meeting with the patient, but also actually accomplishing something with that meeting, right? And it always seems that patients are most motivated to remain adherent to therapy immediately following some kind of event, but just having a single touch point with the patient immediately after the ED visit is not necessarily going to be a long-term solution. So thanks for pointing that out. Carla, I'll come to you next. This question is, what is the most effective way to ensure follow-up after an ED visit?
I think I'm going to go back to my beating the drum of communication. I think if the patient understands that an ED visit is really considered a failure, that something has not worked out, and so if they truly understand what good asthma care or what good living with asthma when it's in control or under control is really vital to really spell that out to them and make them understand or help them understand that if they do need to go to the emergency room or urgent care, that they really do need that follow up because something needs to happen, something needs to change. So I think again, we'll just have to go back to that. Communication is really crucial, and also understanding like if I've had an ER visit for asthma and I call into my doctor's office, that office also understands how important it is to get that patient in. So it's communication on both sides.
Yeah, that sounds like one of the most important take homes from our discussion today is we just need to all communicate a little bit better. And I think this leads really nicely into this next question here. What data should payers share with providers to identify at-risk patients? And so I think this is a two-part question. One, maybe for the payer on the call, what data can we share? And so Drake, I'll come to you with that question. And then I'll also turn to Dr. Lagogo for her insights as to what data would actually be valuable to have been shared with you. So Drake, I'll start with you.
Yeah, thanks, Steve. I'm glad you posed that question that way because I do think, obviously there are privacy concerns around data, and each organization is probably going to feel a bit different in terms of what types of data can be shared. So I don't know that I can necessarily answer that part for everyone, but I think I can say, certain data elements that would be valuable, similar to what I was discussing earlier in terms of those shared goals. I think payers do share the same goals as providers, and I think the payer's role in sharing data should really be to try and augment care. I think a good place to start, would be in connection to that HEDIS measure. Obviously, that is a shared goal to ensure follow-up. So if there are multiple providers who are maybe managing that patient, notifying them when someone has been hospitalized due to an exacerbation and making sure those gaps in care are being closed. If there are specific trends, like we discussed earlier, that you can help flag for those providers to indicate, maybe they're not being managed or are failing therapy, as Carla mentioned. Are they having maybe lack of adherence? There's gaps in between fills of their maintenance medications. On the contrary, are they, being prescribed a lot of short bursts steroids, which is indicative of exacerbation? Those types of things, along with other utilization. And then I think being a bit more proactive as well. Again, it kind of depends on each organization's comfortability, but payers spend a lot of time stratifying based on risk. Whether there's social determinants of health that are involved or other impacts. I think that's the type of data that would likely be valuable as well. When you think about how busy providers likely are when they walk into an appointment, what would be helpful for them. I think, maybe a lower bar for organizations that are maybe more vertically integrated, since they may share EHR connectivity and things like that. But I think there are likely some other creative ways that data could potentially be shared from payer to provider as well.
Great, thanks, Drake. And Dr. Lagogo, I'll come to you for your thoughts. What kind of information is helpful for the provider that the payer might be able to provide in terms of identifying at-risk patients?
I think the one thing we are hearing most from our providers is that they need to be notified in a timely fashion that an event has occurred. There seem to be pretty on in-time data flows from acute care visits and ER visits, like hospitalizations and ERs. There are almost real-time notifications that are captured, and there are multiple data vendors. Each, physician organization is using different vendors, but having the ability to know the event has occurred is important. Where we've run into a snag is with regards to urgent care visits. Those occur at a variety of urgent cares. I think, urgent cares are not highly regulated. They are often standalone groups. I don't know how freely that data flows in terms of the billing in a timely fashion to the to the payer so that the payer can notify the provider that this event has occurred. So 30 days may be a challenge, I believe, with urgent care. So there may be a need to educate patients and provide them, much like you would an action plan, some sort of indication for, the fact that they need to notify you if they have an urgent care visit, because the onus may end up being on the patient, given that it's going to be, I believe, rather challenging if you're waiting for billing to notify you that the patient has been to urgent care. It might be beyond the 30-day period. And so this year, where the new HEDIS measure is being tested, I think in the real world is where our payers and providers and physician organizations will start to see where the pain points might be and come up perhaps with creative solutions to be able to know the event has occurred.
And I just bring in just the asthma action plan Dr. Lugogo brought up, is that's also a really good tool, because with that plan, there should not be an opportunity at a point where a patient goes to an urgent care or an emergency room without already talking to the physician, if that early communication is really set up.
Excellent. Well, we are at time. So at this point, I'll conclude the podcast, and thank you all so much for this insightful discussion. It was fantastic. And once again, I'd like to also thank AstraZeneca for their support on this educational activity. In order to claim credit for this activity, please click the complete evaluation link. And once the evaluation is complete and submitted, then you'll be able to select the type of credit that you require. You have to claim your credit to receive your certificate, or for pharmacists, submit to the CPE monitor. If you have any technical issues, please email impacteducation at info@impactedu.net. That concludes today's program. Thank you so much, and enjoy the rest of your day.